So now gastric part is over, gastric cancer part is over. So we'll move on. Congenital hypertrophic pyloric stenosis. Congenital hypertrophic pyloric stenosis. The name itself is telling. Okay, this is the gastric, the stomach. There is a pylorus, and here is the pyloric stenosis. That is, this pyloric muscle will be hypertrophied. It is a congenital problem. Hypertrophy will be there, and pylorus will be stenosed. So, what will be the symptoms of these babies, newborn babies?
Hyperemesis.
Vomiting. Yeah.
Yeah, symptoms similar to, yeah, everything will be a symptom similar to
Obstruction.
Yeah, GU, that is gastric outlet obstruction. It is seen in the firstborn male infants. Firstborn male infants. Why we don't know? 4 weeks, it's a common age of presentation. Vomiting in infants, it presents with 1 in 3000 live births. Okay, here this is because of hypertrophy of the circular muscle of the pylorus. Hypertrophies. Here circular muscle will be there, right? One longitudinal muscle, one circular muscle. Out of this, the circular muscle will get hypertrophied. Okay, so it is something like your achalasia cardia, right? Here also that lower esophageal sphincter is not opening. Here also the sphincter, that pylorus is not opening. So what you did there? What is the treatment for achalasia cardia?
Myotomy.
Yeah, which myotomy?
Hellas myotomy.
Sorry,
Hellas myotomy.
Hellas cardiomyotomy. Okay, here also you can do something. Yes, so you can see you can do Ramstead. It is known as Ramstead's pyloromyotomy. Pyloromyotomy. Just this is the what do you call, this is the pylorus. You just give a nick there. You just open it up so that it will open up and it will allow the contents inside. Okay, so this is a Ramstead's pyloromyotomy. There we are afraid of reflex, so we did a fundoplication. Here we are not afraid. Even if it reflexes into the stomach, into the duodenum, we are not afraid. So we will just do a Ramstead's pyloromyotomy. Okay. So clinical features are non-bilious vomiting. Why non-bilious?
Because before the
Bile content.
bile.
Yes. D2
Stenosis.
is here. The opening is, the obstruction is here. Okay, so it is always non-bilious vomiting. And on inspection, because of obstruction, we will see visible gastric peristalsis. Because there is an obstruction, the body tries to push it off. So there will be abdomen. If you just see, you can see some visible gastric peristalsis. Okay, and on palpation, you will feel a olive-like mass. The small baby, you will feel a olive-like mass in the right upper quadrant. So GO features will be there, electrolyte imbalances will be there. So these points are important. Okay, there will be a olive-like mass, the patient in the right upper quadrant, and there will be visible gastric peristalsis. So see here, ultrasound is the investigation of choice. So the pylorus will be thick, 4 mm. Pylorus is thick. Normally it is less than 2 mm. Here it is 4 mm, more than 4 mm. And the lengthy pylorus, it is 16 mm, almost 1.6 centimeters. Okay, the length of the pylorus is also increased. The thickness of pylorus is increased. And on barium meal, see here, if you give barium meal, you will see that string sign, because this is a pylorus. It is thickened pylorus, because you can see that string sign. Okay, or the double track or string sign. Only 2 things are available, visible clearly: double track or string sign. So the treatment is Ramstead pyloromyotomy, the same way like Heller's cardiomyotomy. Is it clear?
Yes, sir.
Yes, sir.
And other important point is intestinal atresia. Intestinal atresia, they have bilious vomiting. See, up to D2 is normal. If there is duodenal atresia, from here if it is not there, so he will have bilious vomiting. If jejunal atresia, from here also it is not there, also he will have bilious vomiting. And midgut volvulus, these are all intestinal features of interstitial atresia. So what is this?
Double bubble sign.
Yeah, this is the stomach, this is the duodenum. double bubble sign. Double bubble sign is classically seen in duodenal atresia.
Duodenal obstruction.
Double bubble sign. So double bubble sign, and treatment is duodenostomy. So see, this is the D1. Here it is atretic. Okay. Again it is there. From here it is normal. So what is the best treatment option? You will just bypass it. Duodenostomy. Duodenostomy. That is the treatment option. Okay. For
So
duodenal
it's,
atresia.
it's sorry, I didn't get it. Duodenostomy. Okay, yeah, right.
It is duodenostomy.
Okay.
Okay. So it is double bubble sign. Where do you see triple bubble sign? Duodenum, stomach, duodenum, and jejunum also. Where do you see that triple bubble? Triple bubble is
Says
seen in
jejunal atresia.
jejunal atresia. Same. It is almost the same. Nothing else. Nothing difference. Okay. Yes. No.
So when question is framed, duodenal atresia refers to this double bubble sign. You
Double bubble
never go for an option which says obstruction, right? It's always atresia.
Yeah, it is. Yes.
Okay.
So coming to the next topic, bezoars. What is a bezoar? Trichobezoar, phytobezoar. What is that? Some people-
Collection of non-digestible material.
Yeah, non-digestible material. Some people have the habit of eating hair, small children, or some people fight. That is trichobezoar. Trichobezoar. It is a foreign body. Trichobezoar. And some people eat this phytobezoar, vegetable seeds and all, which are not digestible. They will accumulate inside the body, inside the stomach. They will also have similar symptoms like gastric outlet obstruction. They cause obstruction, and there is a syndrome called Rapunzel syndrome. In psychiatry, you will read about this. Psychiatric patients, they eat their own hair. Okay, this they form trichobezoars. So they present with symptoms like gastric outlet obstruction. Okay, just one word about it. Rapunzel syndrome is important in psychiatry. From our point of view, there are two types of bezoars: phytobezoars, vegetable based, and trichobezoars, hair based. What is this? Just guess. What is this? What is happening here? Normally, the stomach is like this.
It's a twisting of the.
It looks like
Yeah.
a torsion.
Yeah, torsion, or here we tell it as volvulus. Volvulus is nothing but it is rotation around its own axis. Okay, so its stomach can rotate either. See, the stomach is like this tube like this. It can rotate like this, or it can rotate in this way also. Okay, so see here in this diagram, it is rotating up and down. Here it is rotating around itself. Okay, there are two types of volvulus. Longitudinal, if it rotates longitudinally on its own axis, longitudinally, it is organoaxial. Mesentericoaxial, it is vertical. Sorry, this is vertical, this is longitudinal. If it rotates longitudinally, it is organoaxial. If it is vertical, then it is mesentericoaxial. Along the mesentery, it divides. It is the mesentericoaxial, out of which organoaxial is the most common. Just if I can identify these images, it's enough. Okay, volvulus. What is volvulus? Two types of volvulus. Yes, no?
Yeah,
Understanding?
got it.
Longitudinal is organoaxial and
Yeah,
vertical
longitudinal is organoaxial.
and vertical is sir?
Mesentericoaxial.
Which one is longitudinal here?
This one is longitudinal. 1 minute. This one is longitudinal. This one is longitudinal. This one is vertical. Vertical on its own axis, it is vertical. Here it is longitudinal. This one.
Okay, then.
The next slide, sir. One.
Mesenteric is vertical. Okay. So there is a triad here called the Borchards triad. The patient will have pain, abdominal pain. He will be inability to vomit because it has turned the gastric. Normally, if it is there, it will come outside, but it has turned, twisted around itself. So the patient has inability to vomit. The patient has inability to vomit, and the there will be a peculiar thing. The house surgeon will tell, I'm not able to pass the right tube inside. Why?
Because of the rotation.
Yeah, because of the rotation, just it is obstructing. It will not go inside. Okay. And warning, one triad I told you, warning. What is the triad? Triad. In Borjas syndrome, one triad.
Symptoms, right?
What is that?
Reflux.
In Borjas, no, okay, that is different. In dysphagia, reflex, that is okay. But name it triad, I told you in Borjas syndrome. Anybody?
Dysphagia,
Macular striatum.
Very good.
and weight loss.
Macular striatum.
Macular triad. Very good. Okay. So Borjas triad is in gastric variolus. It is pain, inability to vomit, inability to pass Ray's tube. So you should tell me what you will do. This patient comes to you, you're not able to pass the Ray's tube, then what you will do?
Correct the malrotation.
Yeah.
Like fixing it.
Fixing it. So what is that called as?
Sumpexy.
Yeah, gastropexy. That's it. Gastropexy. It is an emergency gastropexy. Okay. Fixing the stomach, gastropexy. And these are image based, just newer questions. Just look at what is it looking like.
Watermelon.
Yeah, this is known as watermelon stomach. Watermelon stomach. This other name is gastric antral vascular ectasia. So some parts will be red and some part is normal. Some part is red, some part it's a vascular condition. Gastric antral vascular ectasia. It is known as watermelon stomach. Okay. So watermelon stomach. It is seen in old age females. Patient with present with anemia and melena.
What is
Treatment
the other name that you mentioned?
Gastric antral vascular ectasia. Okay.
So can you please show the image again?
Yeah.
I'm sorry, I missed it.
Okay. So see here, the vascular part. Some part is red and some part. This is the normal mucosa, normal gastric mucosa, the pale pink one. The red one is because of the vascular abnormality in the stomach. Okay. It happens mostly in the gastric stomach, in the antral regions only, in the down part, antral regions. Okay. The name itself is telling gastric antral vascular ectasia. No need to mug it up. It is in the antrum. There is vascular ectasia. It will lead to watermelon-like appearance. It is seen in old aged females. So treatment is no need to remove the whole thing. Just give laser coagulation. Vessel is there. It is about to get bleeding. So just coagulate it. Okay. Yes.
So just out of curiosity, I'm asking this: how is melena and anemia related to this? I mean, how is it a causative?
No. See, this is because of vascular ectasia that the red areas will bleed occasionally. These red areas will bleed.
Yeah.
So the
Okay.
patient will have melena and she will have anemia.
Okay. So it's due to this volvulus.
Yeah, it is due to this one the patient will present. That is a clinical feature.
Fine. Okay. Got it, sir.
Okay. So next is Delafoy's lesion. This is only for NEET. Till now, I think they did not ask in FMG, but they may ask you. So this is a dilated submucosal bleeding vessel. Suppose this is the stomach. This is the lesser curvature. This is the greater curvature. This is the OG junction. 6 centimeters below the OG junction. That is somewhere here. There is a vessel which will be bleeding submucosally. It will not bleed onto the skin mucosa. It is submucosal bleeding. Okay. So treatment is endoscopic coagulation or embolization of left gastric artery. If not, surgical ligation. So treatment is okay. You can identify, but what is Delafoy's lesion? It is a submucosal bleeding vessel located 6 centimeters below the OG junction on the lesser curvature. Okay. Clear? Is it clear?
Yes, sir.
Yeah. This PPTs I will give it to you. Don't worry. Don't need to just write it off fastly. This every PPT I will share it with you. Okay. And what is this looking like? What is this looking like?
Small intestine.
Sorry.
Polyp.
Stomach.
Any polyp?
Polyp. Okay. No. Something related to human anatomy.
Small
Where did you see?
intestine.
Small intestine.
No. Maybe my image is you're not able to find it, or it is looking like brain, right? Cerebrum. No.
Yes, sir.
Yeah, after you made it clear,
Yeah.
yes, sir.
Okay.
Because
can
you
tell it frankly.
mentioned.
Maybe that image is not proper, but my intention is, it looks like cerebrum. Okay. It looks like cerebrum. This is Meniere's disease. Okay. This is hypertrophied gastric mucosa. This mucosa will be hypertrophied. Okay. So it is looking like this. So this is Meniere's disease. Meniere's disease. Okay. It is caused because of some virus, cytomegalovirus in children, Helicobacter pylori in adults. So just protein supplementation, and we have to remove this because they are pre-malignant condition. We have to do a surgery in this. So just don't get confused. Only 3 things I told you. Apart from congenital hyperpyrolistenosis, Bijors, that is important. After that, we discussed GAVE. That is, what is this GAVE?
Gastric antral vascular rectum.
Yeah. Only 3 things. Don't get carried out. Okay. Just GAVE is watermelon stomach. Just imagine watermelon. That image I showed you, right? That is GAVE. Meniere's is that cerebrum. And Dilophois is, what is Dilophois lesion?
Dilated submucosal bleeding vessel.
Yes, dilated submucosal bleeding vessel. That is Dilophois lesion. Only 3 things. Okay.
What's the reason for giving a protein supplement in this?
In this, because they are viral infections, cytomegalovirus and Helicobacter pylori, both like viral and bacterial infection. So most of them, they are immunocompromised. Is it okay?
Yeah, got it.
Yeah. Yeah. 1 minute. I will take one call. 1 minute. Sorry for that. So only 3 lesions: Dilophois lesion, Meniere's disease, and GAVE. Just 3 new points you learned today. Okay. So what is happening here? Something is getting crushed in between. So yesterday also, what is nutcracker syndrome? What is nutcracker syndrome?
Left renal.
Hypermotility disorder.
Sorry?
Hypermotility disorder of esophagus.
No, nutcracker esophagus is different. Nutcracker syndrome. As day before yesterday, I was talking. Nutcracker syndrome.
Artery gets affected.
Which artery?
Left renal.
Artery or vein?
Left renal vein.
Vein.
Yeah.
In aorta.
Left renal vein gets compressed. Their left renal vein gets compressed. Okay. Here also, the duodenum is getting compressed between the superior mesenteric artery and the aorta. Okay. It happens in tall, thin, young females. Okay. So because of rapid weight loss, this happens, and it also happens in cast syndrome. Suppose earlier days they used to put a cast over the abdomen. Okay. The orthopedicians, they used to put a cast. This also will cause compression, and the aortomesenteric angle will be decreased. The aorta and will be there, superior mesenteric artery will be there. It will compress the duodenum. Okay. So what we will do is, can we divide both of them, aorta or superior mesenteric artery? It is causing compression, right? So can we divide it?
Sorry, so I'm so lost. So it's called SMA syndrome. SMA in the sense? Superior mesenteric artery syndrome.
Superior
Okay.
mesenteric artery or Wilkes disease. See, this is the duodenum. This is the aorta. This is the superior mesenteric artery. Okay. Suppose a structure is being compressed. A structure is being compressed between superior mesenteric artery and the aorta. So what you will do to relieve the compression?
I don't know, colloquially, maybe like spread it out or something.
Yeah. Suppose see, if something is being crushed between two things, we will just remove one offender. That's all.
Like
But
decompressing.
yeah, the decompression. But here what is happening? Here both are important. Aorta is important, superior mesenteric artery is important. So we will bypass the duodenum. We will just do a bypass. Okay, we will let this be like that only. So we will connect the duodenum to the duodenum. We will do a duodenum duodenostomy or a duodenum jejunostomy. That's it. Okay. So basically, superior mesenteric artery syndrome or Wilkes syndrome is nothing but it is the compression of duodenum between superior mesenteric artery and the aorta. The same way, nutcracker syndrome is nothing but compression of left renal vein between superior mesenteric artery and aorta. Just remember these two things.
Compression of duodenum between superior mesenteric artery and aorta. No, sir.
Aorta. Superior mesenteric artery syndrome or Wilkes disease. Whereas nutcracker syndrome is compression of left renal vein between superior mesenteric artery and aorta. Nut. Remember nut. Okay, it is kidney. So left renal vein. Okay. Yes.
Yes, sir. Sir, can you please explain this with the image?
Yeah.
Yeah.
This is not proper. Okay, just a picture. This is the aorta. This is the aorta, right?
Yes, sir.
This is the superior mesenteric artery.
Okay.
Okay. So this is compressing the duodenum.
Got it, sir.
Okay. Yeah. It is seen in tall, thin, young females and in cast syndrome. That is, if you put a cast very tight on the abdomen, this will happen.
So the bypassing is which way, sir?
Yeah, I'll tell that also here. So here what we'll do is we will do a duodenum. We'll cut this, both of them will cut it off here, and we'll do a anastomosis again here. Okay. We'll cut this here. We'll cut this here. Let it be like that. So we'll do an anastomosis again. Got it?
Yeah, the chopped off part will not have blood supply, so it will necrose, sir.
Yeah, it will necrose, and even if whatever happens, it is okay for us.
Yeah.
Okay, we are just bypassed it, right?
Yes, sir.
The luckiest thing is it happens more in D3, not in D2. If D2 is compressed, we cannot do anything because D2 only all the things get opening. All the things are opening here. D3 is little okay. Okay. Yes.
Okay, sir.
Okay. This upper GI bleed, hematemesis, melena, hematochezia. We have discussed management. Bleeding duodenal. Bariatric surgery. So only one word about bariatric surgery. What is this bariatric surgery?
So is it
Chopping
got to
off
do
the
something with,
weight reduction.
sorry.
Yeah, weight reduction. So actually there are two types of bariatric surgery. One is restrictive surgery, and the other is malabsorptive surgery. Restrictive surgery and malabsorptive surgery. So what is the basic difference between these two is restrictive surgery, we do sleeve gastrectomy, known as sleeve gastrectomy. Sleeve gastrectomy. Suppose this is the stomach. So what we will do is we will put a stapler here and we'll resect the sleeve off. We'll remove it. So what happens now? What happens now?
So its stomach becomes smaller.
Stomach becomes smaller. So whenever we eat a smaller meal, the patient will get satiety. He will not be in a mood to eat much because the stomach capacity has become less. So this is known as restrictive bariatric surgery, sleeve gastrectomy, restrictive bariatric surgery. Okay. Yes, no?
Okay.
Okay.
Yes, sir.
So the next is malabsorptive bariatric surgery. Here there is another technique which people follow. See, suppose this is the stomach, this is the duodenum, this is the jejunum. Okay, the jejunum and small intestine, jejunum, ileum, and most of the colon is there. It will be bypassed. Those part will be bypassed, and the stomach will be connected to the ileum directly. Okay, so whatever food is there, it will go directly into the ileum. These juices will go and mix with the food in the ileum. So the absorption capacity, normally if you take suppose 100 calories, it is getting absorbed. Almost 90 calories is absorbed, only 10% is going through the feces. Here, only 30 to 40% is absorbed. The rest is going undigested. So this is known as Roux-en-Y bypass. Roux-en-Y bypass technique. This is a bypass technique which will cause malabsorption. So what is the side effect with this? So what will the patient experience along with weight loss? He will have loss of, what else he will have? Loss of weight will be there. That is what we intended for. But any other loss also?
Anorexia.
Sorry?
Loss of appetite.
Loss of appetite will be there. Okay. But the minerals, the vitamins and all also are not absorbed, right?
Malnutrition.
Absorption, nutritional deficiency.
Yeah, he will have nutrition deficiencies. So we have to prescribe him some multivitamins. Okay.
Sorry, so the name
It is Roux-en-Y bypass. Roux-en-Y. X is silent. Roux-en-Y bypass.
okay,
Okay. Yeah. There will be Y shape. Okay, like this. This is the gastric. Suppose this is the gastric, ileum, and this is the duodenum, jejunum, ileum. So the bile juices will come from this Y, and food will come from this Y. So it is a Y junction. It forms a Y, Roux-en-Y. Okay.
so we don't chop off this connection from the gastric part to the duodenum, or it's just bypassing thing we will do now, sir?
We don't remove anything. We just bypass it. That's all.
Okay. So in part of food can also pass through duodenum too, right?
No, we will do in such a way that dependent manner we will in while operating will so a dependent manner will be ileum only. One thing.
Oh,
And second thing, at the gastric duodenal junction there is a pylorus. Okay, this is the
yes.
sphincter. The
Yes.
pylorus will be closed. Here we have an opening. Ileum will be always open. So food will obviously it will choose a easy
Yes,
way.
sir.
So it will
Yes.
just go into the ileum. It will not go into the pylorus. After few days, what will happen? This pylorus will go into stenosis. If it is not getting
Okay.
opened frequently, it will go into stenosis. Okay.
Okay. Thank
Yeah.
you.
So now we'll move on to the last topic, intestines. It is intestines anatomy part. I'll just skip because this one. The intestine is almost of 6 meters. Okay. Jejunum is of 1.5, 6 meters, 600 centimeters it is. This much long abdomen. If you see any, I think you might have seen some operations where we open the abdomen and you can find only the intestine. So 1.5 meters is around the jejunum, 4.5 meters is the ileum. Okay. So how to differentiate between jejunum, ileum and all in anatomy, I think they'll discuss. If not, just add it in our list so that we'll discuss in the next time. Okay. This is the anatomy topic. How to differentiate between jejunum, how to differentiate between ileum. Yes, no?
Yes, sir.
Okay, sir.
Okay. So this is the radiographic appearances. This is important for us. This radiographic appearance. See, this is the, I'm telling, I'll on seeing this, can you tell it is jejunum or ileum?
Jejunum.
This
Jejunum.
is jejunum. This is jejunum or this is A or B? This is A. This is B.
A is jejunum.
Okay.
B is ileum.
How?
Because markings.
Markings.
It means
Okay.
fold.
Okay. Before that, is it small intestine or large intestine?
Large intestine lies.
Small intestine. Because
Small
it's
Yeah, it is
small.
small
Both
intestine.
jejunum and ileum are small intestine.
Small intestine only. But how come you are so sure that it is small intestine? It
Small
may be large.
Center.
It is large
It's in
intestine.
center.
centered more.
Yeah, very good. So if you find any bowel loops in the center, it is small intestine. These are also in the center. It is small
Peripheral
intestine.
is large.
Peripheral is large
Large
intestine.
intestine.
Okay, that is one point. Second point, see here carefully. If you see, this is having a small appearance. This concentric appearance is there, right? So this appearance is known as valvulae conventis. Valvulae conventis. Valvulae conventis. It is nothing but keeping bangles, stack of bangles, one bangle after one bangle. Like you can just keep 100 bangles like that. So this appearance of jejunum will be like keeping a stack of bangles. Okay. This is valvulae conventis. If you see properly, are you able to appreciate it? Yes, no?
Yes, sir.
Very clearly, sir.
Yes. Okay, good. So this is valvulae conventis. Here, see, this is just tube-like things. Nothing is there. Just tube-like. Nothing. So this is known as featureless. If the term that they put forward is featureless. If it is looking featureless, this is ileum. In the center only. In the center, if it is looking this like valvulae conventis, it is jejunum. Okay.
Okay, sir.
And see here, large bowel is periphery, small bowel is central. Jejunum will be valvulae conventis. This for spelling C. And ileum is featureless. And see here, this is periphery. This is also periphery. Periphery, I mean in the upper also periphery. This is also periphery. So this is a large bowel. Okay.
Yes, sir.
Are you able to appreciate this? See here clearly, large bowel. And what is this here?
Jejunum.
What is this? What is this appearance known as?
Stack of bangles. Valvulae conventis.
Valvulus conventis. Very good. Okay. Colon, marginal artery, Griffith point. These are all just I'll skip. Okay. Ischemic bowel diseases. We'll go on to the important ones. Ischemic bowel diseases. Lower GA bleed. Yeah.